Okay, and we are live. Hello, web shadowers. Thank you all for joining our session this evening. Today we have the pleasure of hosting Dr. Nikolas Parisis, who will be teaching us about radiology. As always, please remember the Google form will be posted in the chat box and in the description of this video at the very end of the session, and you'll have 30 minutes from then to fill it out for attendance. With that being said, you can get started whenever you're ready, Dr. Parisis.
Thank you very much for that introduction. Today's presentation, I wanted to basically touch on kind of radiology as a specialty. We'll talk about like what it is, why I chose it, and a little bit about artificial intelligence, and then kind of the structure of residency. And then we'll talk about some kind of basic clinical radiology cases, and of course, look at some imaging, and then we'll wrap things up. So I hope you guys find this informative and helpful and insightful maybe in picking a medical specialty, because in my opinion, radiology is the best kept secret in medicine. So if you haven't already, make sure to follow me on Instagram and TikTok. I post about kind of daily life as a resident, as well as COVID-19 updates and kind of everything in between, like pre-med stuff about radiology, of course. So yeah, we'll get started. So here is a picture of the very first radiograph taken. And this is his wife's hand with her ring on it. So this was just before the turn of the century, and this was over 100 years ago. So this is the very first X-ray ever taken. So a little bit about me. So I thought a map would be a little bit of a more direct way to kind of show you guys where I'm from. So I'm from a small town outside of Sacramento, which is closer to another town called Stockton, which is closer to where I'm actually from, which is Lodi. And this is close to San Francisco, for those unfamiliar with Northern California. And for undergrad, I went to the University of California, Santa Cruz, and graduated in 2014. And then I took some time to study for the MCAT, and I took 2 gap years. I lived in San Francisco for those 2 gap years, and I worked at a Google Glass startup, and it was a really great experience because it kind of gave me some time to polish my application and basically apply to medical school and do some traveling. So then I started medical school at the Lake Erie College of Osteopathic Medicine in Bradenton, Florida, which is confusing because it's called Lake Erie College because they have another sister campus in Erie, Pennsylvania. So I went to the Florida campus. And so I did my first and second year of medical school, which is kind of the preclinical years, or like the book work, in Florida. And then LECOM, or Lake Erie College of Osteopathic Medicine, also has a rotation site in San Diego. So one of the reasons I chose LECOM was because I could potentially go back to California for rotations. So I did my 3rd and 4th year rotations in San Diego, and then I matched for residency at the University of Minnesota in Minneapolis. So I'm currently in my intern year at Hennepin County Medical Center. And intern year is basically your first year of residency, where you kind of become a general doctor before you start your actual specialty. And so that's kind of like where I'm from and kind of my path to and through medicine. And some of my hobbies, like that I really have tried to keep up, and I think it's really important to keep hobbies up. One of them is playing traditional Greek folk music. So I play music from the island of Crete in Greece. And I think it's really important to kind of keep those hobbies up to stay well-rounded. In college, I also played rugby. So I do have a background as a D1 AA athlete. And then in high school, I was a wrestler. And then now I just kind of do my best to stay fit and limber. And then now I've kind of started to do more social media stuff because I started posting about new research and science that is coming out about the pandemic, of course. And my friends started really appreciating that. So I kind of created a separate page kind of dedicated to that. And now it's kind of morphed into a little bit more about residency, pre-med stuff, radiology, all that stuff. And here's a picture with me and my family at my college graduation in Santa Cruz. So medical school is crazy because it's kind of like the analogy is it's like drinking from a fire hydrant. So you get so much information just blown at you. And the only way to manage it, I think, is to come in from the sides for small sips every day. So I think that's a great analogy. It's a really common one. Another really common analogy is that medical school is kind of like eating pancakes. And med school is very interesting. So a lot of the things that we learn are super interesting, and it can be very engaging to kind of learn about all this different stuff about the human body. But the thing is, you have to learn this stuff every day and really dedicate your life to coming back to it every day. So it's like someone giving you a stack of pancakes and you're like, great, I love pancakes. But then you have a stack of pancakes every day, and sometimes you don't want to eat a stack of pancakes every day because it gets kind of old. So I thought that was a fairly appropriate analogy that I hope you guys find insightful. So basically, I worked at a digital health startup for my 2 gap years in San Francisco. It was a company called Augmetics, and it was a company that focused on remote medical documentation. So kind of like remote scribing for doctors using the Google Glass unit, which has a microphone and a camera on it. And so you're able to stream through the Wi-Fi, the audio and the video of, let's say, a physician talking to a patient. And then the charting could be done in real time. So it was a really nice experience because I got insight into a lot of different medical specialties and kind of informed my decision about where to take my own career. So after that, I got to med school. I really didn't know anything about radiology, but I did do some research in biochemistry, and it was computational biology research. And I really liked kind of the digital side of this biology and science stuff. So then I thought to myself, like, okay, I've heard about radiology. Seems like a pretty cool specialty. I don't know much about it. What's it all about? So I did a rotation early on in my 3rd year when I thought I was interested in it. I did a small case report, and so did a little bit of radiology research and ended up really, really enjoying it, actually. So I went through the rest of 3rd year doing all those core rotations, all the basics, surgery, medicine, pediatrics, psych, OB, all that stuff. And at the end of that, I realized, like, okay, I think radiology is still what I want to do. And after doing some elective rotations as a 4th year, I definitely realized, like, this is truly the best specialty for me. And this is kind of a funny cartoon, I think, because, they say, you'll never amount to anything staring at, the TV all day. And radiology is as close to a computer job that you can get to. So it is kind of like a tech job, which is nice in its own way, if that's what you're looking for. So this is, I guess, the dad saying, son, I'm so glad that you made something of yourself. So this is kind of what radiologist workflow looks like. We have like this really nice computer setup, and we pull up our imaging, and we have our work list, and we do our work with these like super high resolution monitors that cost as much as a small car sometimes. They have like 6K resolution or 8K resolution, and they can be like $16,000 or $20,000 per monitor. So we get this really cool workstation setup. And we also have like a dictaphone, which we basically talk into and dictate our report. And it kind of recognizes all the medical jargon that we use in our reports. So radiology is basically the eye of medicine, because some things, when, let's say, a doctor in the emergency department comes to evaluate you, let's say for abdominal pain, sometimes we don't really know what the cause of the abdominal pain is. So oftentimes imaging is ordered. So it could be like an abdominal x-ray, could be an abdominal CT scan, et cetera, and so on. Could be a gallbladder ultrasound. So there's, radiology kind of has its tentacles into almost every specialty in medicine, maybe except for psychiatry. So some of the imaging modalities that we use are, of course, radiographs or x-rays, CT scans or CAT scans, ultrasounds or sonograms, and of course, MRIs or magnetic resonance imaging. And then we have also nuclear studies where we use radioactive material to kind of study the physiology of the body. So basically, radiology, in short, is we use imaging to make diagnoses primarily, and we also use imaging to treat diseases. And we basically, the job of the radiologist is to kind of help or guide the clinician or the surgeon and to help them make a decision clinically for a patient. And so we do, of course, we do a lot of diagnostics, but we also do procedures. So we do all sorts of different procedures. We also see patients, although not as much as maybe other specialties. There are two subspecialties in radiology who do see more patients, and that's interventional radiology and breast imaging. Of course, we also have to do protocoling, which is kind of deciding which type of study is the best for what the clinician is looking for. And then we also deal with contrast reactions because we often give IV contrast to patients to kind of get a more detailed look inside the body. And so some people are allergic to that, develop anaphylaxis. We also learn about radiation safety, of course, and there is a component of physics. The medical physics that you learn in radiology residency is a little different from kind of the kinematics and the pre-med physics that you learn. So yeah, that's a little bit about medical aspects of radiology. There's a lot of misconceptions about what the radiologist does. Some people think we just dictate into a microphone. Some people really don't know what we do. Some people think we shoot x-rays. Kids might think that we play video games, and other people, think that we're just in the dark all the time, which is, somewhat true. Our workstation is kind of in a darker room to kind of see the imaging better. So I want to also talk about some of the non-medical aspects of radiology. So the scans per shift that you might see or read widely varies. So it could be anywhere from 20 or 30, CT scans, PET scans, MRIs in a day, or it could be 100 to 200 X-rays in a day, or ultrasounds, for example. So, it's often like a mix of all of that stuff. So it really ranges, and there's quite a lot of variety. So the typical hours, basically radiology is shift work more or less, and the typical hours are kind of like banker's hours. Of course, there's call. So, you might have to work in the evening or overnight. And as a resident, we do work overnight, and it's kind of like a really good independent kind of learning opportunity because you're the go-to person to kind of make the calls and help people make decisions who are on the front lines. And of course, vacation is kind of on the upper end of physicians. So that's I think a huge plus to radiology. I think the salary is also something that should not be something that is taboo to talk about. So I think the salary is another very positive aspect about radiology. There are some differences between private practice and academics. Academics is kind of like your more traditional university setting radiologist who basically you would read more of what you are fellowship trained in or subspecialty trained in. So if I was a musculoskeletal radiologist, I'd be primarily reading musculoskeletal imaging or sports imaging. In private practice, if I was musculoskeletal radiologist, I'd probably be reading that anywhere from 25 to 50% of the time. And then the rest of that would be kind of general because you're more in the community setting and basically just helping get through the workload. So that could be all sorts of chest x-rays or head CTs or abdominal ultrasounds or mammograms, for example. So there's also some differences between rural and urban. And, similarly, like in the more rural communities, you'll be more of a general radiologist. And there's a very high need for radiologists in the rural communities. Whereas in like a more urban setting, it would be more similar to maybe like an academic setting where you're reading a little bit more of what you're subspecialty trained in. Of course, there's malpractice to talk about. Radiology is not the most litigated specialty. I think number 1 and 2 is plastic surgery and OBGYN. I think radiology is kind of on the medium high end of that rank. So just something to keep in mind of because you can often miss like a lung cancer on a chest X-ray that comes back. A patient might have a lung cancer that comes in 5 or 10 years down the line. So oftentimes our names are on the report. So what does a typical day look like for the radiologist? Well, for a lot of doctors, this is kind of what the day looks like, where you get up, you are basically at a computer all day long, and in between, you might be seeing a few patients, doing some procedures, et cetera, and so on the phone, doing your day-to-day stuff like driving to work and eating, of course. And so I kind of enjoy this aspect of radiology where you get to take a seat and you're not like on your feet all day long. And yeah, this is I thought a nice cartoon. So why did I pick radiology? So many reasons. So I hope this is helpful for you guys. So imaging is super, super important in medicine. So we have a direct impact on patient outcomes, meaning that our report really, really matters. Basically, what we say in the report will directly affect what the clinicians on the front lines will do with patient care. So I found that a very rewarding aspect of radiology. It's a very, it's a very interesting field for that reason too. So we do have to know a lot for that reason because we interact with a lot of different clinicians. So another nice aspect about radiology is that you could just show up to your workstation and you have very little paperwork, very little bureaucracy. You're not making phone calls to the pharmacy, the insurance company, or trying to coordinate patient care for very complex social discharge situations and patient dispositions, like where's this patient going to go, stuff like that. So we're more focused on the science and pathology disease aspect of things, which I thought was a positive aspect for myself. There's also a really big teaching aspect and research and, of course, studying aspect in radiology. So we have to study quite a lot in residency, compared to other specialties because there's a lot to know. So they say the good radiology resident reads around an hour a day and the bad one reads no hours a day. So there is a lot to know. There's a lot to study. And you kind of pick things up through osmosis, I think, throughout the years. So just something to keep in mind because, residency is 6 years long for radiology, and there's, a lot to know for good reason because a lot kind of rides on your diagnosis. And oftentimes the radiologist is called the doctor's doctor because they, like, for example, an oncologist might come to a radiologist to want to discuss certain imaging findings. So I think that's a really cool position to be in, to be kind of like a consultant like that, and for so many different specialties. And I'd say overall, the field is generally like chill people and fairly laid back. Like the reading room is a pretty laid back place to be, not super high stress or super loud. So I thought that was a great aspect as well. This is kind of physician pain scale, like, would you do your specialty all over again, or like how happy are you with your specialty? And on the far end over here, we have, you can read them here. There's nephrology, of course. I don't know how accurate this is necessarily, but radiology is over here with like ortho and plastic surgery, derm, as you can see, oncology. So people seem to like the specialty. So oftentimes imaging is what I like to say is the physical exam of the 21st century, because when you go to examine a patient, you can only get so much information, and a lot of the physical exam maneuvers that you do are not very sensitive or specific. And oftentimes the imaging is much more accurate or much more sensitive and specific for a certain diagnosis to kind of figure out what's going on. And so I kind of talked about the breadth and diversity of the pathology that we see. We interact with a lot of different specialists throughout the day. I think the variety is really cool. I think it's also the radiologist has a very cerebral workflow. So if you find yourself being more of a thinker rather than a doer, like you want to work with your hands all the time, I think diagnostic radiology is great if you want to go more the thinker route. But we also have a lot to offer for people who are more doers, or for people in between who want to do both, do procedures and have a more cerebral workflow where you're not necessarily working with your hands. So as I said before, interventional radiology and breast imaging probably offers the most procedures in patient care. And the reading room is a pretty lower stress place to be. And I've noticed that people switch over into radiology from other specialties, but once you're in the specialty, you generally don't leave. So once I started to realize that, I was like, oh, okay, something's going on here. And as I said before, The physical exam of the 21st century is the CT scan sometimes. This is kind of the donut of truth that, it has all the answers if you want to do a chest CT or head CT or an abdominal CT. And the history and physical exam are very, very important, but sometimes you can't do them because the patient is sedated or unconscious, they have altered mental status, and they can't quite cooperate and give you like a history. And so yes, oftentimes we just have to scan them to figure out what's going on. So here's some more reasons why I chose this specialty. I thought it was very medically interesting. I really like the technology aspect of it, how kind of innovative and cutting edge and relatively new it is because, MRI and CT imaging has been around for 40 years or so. And now artificial intelligence is coming around. So that's kind of the new big thing. And there's always going to be something new. And imaging is going to find itself, it's always going to be necessary in medicine. Another awesome aspect about radiology is shift work, because once you show up for your shift and if you're done at 5 o'clock, even if you get a CT scan or an X-ray that comes in like minutes before, you can basically read it and like get the task done. So it's more task oriented, and then basically leave and get on with your life and go home and enjoy your family or your hobbies. So it's not like, you get like an admission, and then you end up staying and having to like do things for an hour or two, at the end of your shift, for example. So if you like kind of checking off tasks on like a checklist, then I think you might like radiology. Another awesome aspect. So there are lots of fellowship options, which I think people don't know about. So for that reason, it offers a lot of career flexibility. And there's interventional radiology, breast imaging, musculoskeletal imaging, neuroimaging, abdominal imaging, pediatrics, and nuclear medicine, of course. And so each of those specialties has kind of a different lifestyle. Of course, they're similar in some aspects. And I think the awesome aspect about our field is that you can have as much or as little patient interaction or procedures as you like. And of course, if you decide to do primarily diagnostic work, this lends itself really nicely to teleradiology or working remotely or working from home. And I think in COVID, we all kind of know how things are now with Zoom University and all this stuff. So being a kind of computer or tech job is like maybe not such a bad thing. I think that's an awesome feature of the specialty. And we also have work-life balance, which is not something to be underrated or it should be something that we discuss, because work-life balance is not something to be overlooked, because burnout is very high. Physicians have higher than average suicide rates, and I think it's very, very important to talk about, because it's not like work and life are completely separated, but they are related and both affect the other. So what happens in your work life affects your life outside of work, and et cetera, and so on. So this is a kind of a cartoon with SpongeBob here, kind of, the emergency doctor is saying like they need a scan right before your shift is done at whatever time it is. It's like we're trying to hide to not have to do it, but of course we'll do it. It's just like a funny cartoon. But you might, let's say, read the X-ray like minutes before the imaging comes in, and then you're done like a few minutes later. So, of course, procedures are a nice aspect of radiology. If you are in musculoskeletal imaging, you might be doing joint injections, like putting steroids in all sorts of joints, feet, ankles, knees, elbows, shoulders, et cetera, and so on. If you are a neuroradiologist, you might be doing a couple lumbar punctures per day, let's say to look for meningitis or to take a sample of the cerebrospinal fluid. If you're in pediatrics, you can do what's called an intussusception reduction. If you are an abdominal imager, you could drain abdominal abscesses, of course. If you're in breast imaging, you'll do all sorts of breast biopsies and counsel patients on all of that. And if you're in interventional radiology, then you do over 200 different procedures. I think this is very, very unique because even as a surgeon, you may be doing anywhere from 5 bread and butter procedures up to like 20 or 30 different ones, but there's so much variety. And IR is basically where you do like minimally invasive surgery, like you do minimally invasive image guided procedures basically. And you can do all sorts of stuff right here. So definitely encourage you guys to kind of follow some interventional radiologists online and see kind of what what procedures they do, because they really do procedures all day long. It's a really cool aspect. Even as an IR doctor, you can do some diagnostic work and some procedural work. So it could be like a 50-50 split or a 70-30 split. So it's pretty cool. So residency is basically, for radiology anyways, it's split into the first year, which is an intern year, the second through fourth years, which are the diagnostic radiology years. And then after that, you have to do fellowship for a year. So I kind of talked about the fellowships that we have before. Neurointerventional is kind of the exception to the rule of all the fellowships being 1 year. Neuro IR is 2 years long. So for example, I'm currently at Hennepin County Medical Center for my transitional year, which is an intern year. There's other types of transitional year, or there's other types of intern years. One of which is internal medicine, and then the other of which is general surgery. So I happen to be in a transitional year program, and then starting, PGY 2 through 4, I'll be at the University of Minnesota. And then this is kind of our question bank that we use to study from. Rad Primer, pretty much everyone uses it, and then Core Radiology is a kind of a bread and butter book that we use. There's multiple ways to get to interventional radiology. You can either apply directly to it right after during medical school, or you could go through diagnostic residency and then do early specialization in IR, where kind of halfway through residency, you decide, I want to do IR. The other way to do it is to go all the way through diagnostic residency, so 5 years in, and then do a 2-year fellowship. So that'd be 5 + 2, that's 7 years. And 6 years is kind of the usual amount of years for training. So you might be asking yourself, well, what about artificial intelligence? Aren't we going to be replaced by just these AI algorithms that can read the imaging? Well, Dr. Salini, he's a really big YouTuber. I really like this video that he did. He talks about this. AI is a huge field. It's something to be very, very excited about because it's basically going to improve patient outcomes and the accuracy of our diagnostics. And, we already have it in mammography. We already have it with EKG readings. And, people will tell you it's like not that great. And, some non-medical people will say, or even some physicians will say that AI will replace a radiologist, but ultimately it's going to be another tool in our toolbox. It's only going to supplement the radiologist to help us do our job better. So if we can see more imaging and read it, in a more accurate fashion, then it's only going to be a benefit, I think, to society and to the radiologist workflow. So this is kind of a timeline of the evolution of radiology. I shared that first radiograph with that, a picture of the hand with the ring right around the turn of the century. And then we slowly had all of these imaging modalities developed that I talked about before. We had, transcriptionists before, and then, the physical exam is forever lost. And then, some people think, AI ends the human race. So we'll see kind of where this goes. So that begs the question, what about liability? This is the robot saying, I missed a diagnosis. I'm being sued. Like, what do I do now? Well, of course, that's why you have an actual human who can kind of tell you like how I got to the certain diagnosis that I got to. Or from a student, I can kind of give you knowledge like, hey, this is how I got to, this is the thinking process that I went through in my own mind to basically give a diagnosis, for example. And the AI algorithms are basically black boxes. They can't explain to us how they got to where they got to. That said, they can digest a lot of data and come up with very, very precise algorithms that are very pinpointed, but not always clinically significant. So I hope you guys find that helpful. I think AI is a awesome aspect of radiology, and it's something that's just going to be implemented in our workflow in the future. So what the practice of radiology looks like today will likely be very different from what it looks like in 20, 30, or 40 years, which is pretty cool. So I'll just stop here and ask you guys if you have any questions. And then we'll get started into kind of clinical cases and go over some basic anatomy and imaging, of course. So this question is there a difference in the radiology residency training for an MD versus DO? So not necessarily. So most of the radiology residencies are, so I'll just preface this by saying in 2020, all of the residencies, MDs and DOs, they combined into a single application process. So for the first time, I graduated in 2020. For the first time, I applied to all of these residencies, and basically it was one application. This is different from how kind of residency applications were prior to 2020. But basically, most radiology residencies were historically or are historically kind of MD paths. And so DOs can also apply to these programs. There are other programs in other specialties that are historically DO programs. So the training is I'd say equivalent. There's no real difference besides like kind of the board certification that you get. Like, do you go through the osteopathic boards or the allopathic or MD boards? So as a DO, you can go into any residency program for radiology. So this question is, why did I choose DO versus MD? So this is a super common question I get. I think that basically what you have to do as a pre-med, or like what I had to do, was just apply it to medical schools and see where you got in. It's kind of like, you can't like say you picked a medical school if you only got one acceptance. So for example, I applied to 30 schools, 15 were MD and 15 were DO. So I knew that based on my statistics where I had to apply to. And I ended up getting 8 interviews. So 8 out of 30, and then 2 acceptances out of those. So it's super competitive, as you guys know. And so I got 2 acceptances, both to DO schools. And then my decision algorithm was basically, how do I decide between the two? Well, I looked at, of course, tuition. I looked at location. Looked at board scores, because you don't want only those students to have like high board pass rates, but you want them to have a higher than average board scores. So I thought that was a appealing aspect to my medical school. And then also, I think kind of the residency match list, like where do these students actually end up when they graduate for residency? Is this somewhere, are they matching into the specialties that I want to match into? Are they matching geographically where I'd like to be? So these are all things that I considered when kind of choosing a medical school. Yeah, so this next question is, can you talk more about the startup and why you chose that? Yeah, so I was studying for the MCAT. So the timeline is basically in May of 2014, or June rather, I graduated from college, and then I spent about 4 months working as a medical scribe in the emergency department, which is very common. And then after that, I took 3 or 4 months to study for the MCAT. And in that time, I had this company reach out to me on, I think, LinkedIn. And they reached out and they were saying like, hey, this is what we're doing. And then I interviewed and ended up getting the job. So I basically started working right after I took the MCAT. And so I didn't necessarily choose it. They kind of found me. And it was just like a really cool place to live and to work. San Francisco is a fantastic city. I got to do a lot of traveling, both for work and for personal stuff. So that's kind of how I spent my time during the gap years, and kind of what the startup was about. Basically, if you can imagine, there was like a virtual, kind of like what you guys are doing now, like a virtual camera and video into like what the physician was doing or was seeing. So if they were doing certain physical exam maneuvers, or I could hear all the questions that they were asking the patient. So I got a really good look into what kind of outpatient medicine looked like for a lot of specialties, for orthopedic surgery, rheumatology, family medicine, and internal medicine. So I thought it was a really, really great opportunity. Yeah. Any other questions? Otherwise, we'll kind of jump into things. In regards to the MD and DO thing, I did. So if you go to my Instagram, I did do 2 posts about this, kind of just detailing kind of the minor differences, because at the end of the day, the differences are kind of they're irrelevant. They're not really super important, I think. But there are some nuances in kind of the philosophy um, of the kind of training pathways that are important to know, I think. So just kind of know about those little differences, and yeah, I think that those 2 posts should kind of sum up kind of what are my thoughts on kind of the differences between the two, because there really are more similarities than not. So we'll jump into some cases now. So basically, chest x-rays look like this, and they don't always have all the anatomy listed like this. So as you can see, we have the airway here, the trachea, the carina is where it bifurcates or splits, and then we have the clavicles, of course. The lungs are split into the apex, the upper, middle, and lower lobes, and then same on the left side. Of course, we have the cardiomediastinal silhouette. We have the different chambers of the heart here, and then we have chest CT anatomy, which is, as you can tell if we go back, it's the chest CT is a little different from the chest X-ray. So we have all the same anatomy more or less. We have the left hemidiaphragm and the right. This is the entire diaphragm. The costophrenic angle. Sometimes fluid likes to sit in here. Kind of blunt these angles is what we call it. So of course there's the scapula back here. So if we kind of compare that to the chest CT, you see kind of the airway a little bit better. And you of course see the lungs very well. You can see all the ribs coming through. So of course the liver sits on the right side over here, and the stomach is over here on the left. Kind of catch the spleen here. So this is some basic anatomy just to kind of keep in mind as we go through these cases. So this is the first case. We have 5 cases total there, and I hope you guys enjoy these. So these arrows wouldn't necessarily be here on like an actual patient, but just to kind of simplify things. So this case is obviously a chest x-ray, 65-year-old female, and this person has a history of COPD, which is lung disease, most often caused from smoking, of course. She presents with a fever, so we might say that she is febrile. She also has dyspnea or shortness of breath or difficulty breathing, and has sputum production, which is green and yellow in color. She also has pleuritic chest pain, and that is basically chest pain that you get when you take a deep breath in. So every time you inspire, you have chest pain. That's called pleuritic in nature. She has tachypnea, so elevated respiratory rate or faster rate of breathing, and tachycardia, which is an elevated heart rate. And on physical exam, you might auscultate with your stethoscope. You might hear some crackles on the right side. So we kind of take all of these history and physical exam findings. You guys are probably familiar with the SOAP note at this point. And then we might do some lab work. So we might get a CBC and look at the white blood cell count and see that it might be elevated. And so we call that leukocytosis. And so what do you guys think is the diagnosis here? Any thoughts on kind of what's going on? If you put all of this stuff together, as far as a kind of a clinical picture here, so this is kind of where imaging would fit in. It's like another data point to kind of figure out what's going on with the patient. So it's kind of like putting all the pieces of the puzzle together. Yeah, so sputum, basically, I'm just saying that they have sputum production, or they're having kind of green and yellow mucus. So this patient has fever, difficulty breathing, hacking up sputum, it's green, and yeah, so it's a great thought, fluid in the lungs. Um, they have chest pain when they breathe in deeply, kind of fast heart rate, breathing fast, and crackles. And then, of course, elevated blood cells, which are often a marker of infection or inflammation. So, yeah, basically here we have a kind of classic right lower lobe opacity that is consistent with what we might call a bacterial pneumonia. So, awesome. And speaking of pneumonias, you guys are probably familiar with COVID at this point, and this is what a COVID pneumonia might look like. This is a really great Instagram channel if you guys want to follow the radiology guy. He has just a fantastic page with these really beautiful overlays. And what you see in COVID pneumonia is, this is a chest CT, of course, and this is what we call peripheral ground glass opacities. Basically junkiness in the lungs, and you see some consolidation here. So yeah, that's kind of COVID pneumonia. So we just went over a chest x-ray. This is a cartoon showing the importance of a not only AP view or PA view, which is forwards and backwards of the chest, but also of a lateral view or a side view, right? Typically done on the left side when we do these chest x-rays, because you're looking ultimately at a two-dimensional object that is representing a three-dimensional structure, aka the human body. So if you are looking at things, head on, you might think this lion is just, kind of is eating the pup's head, but really they're just carrying them like that. And then this is kind of a lateral chest x-ray. So, you see all the vertebra labeled here. This is again the radiology guy, the sternum and the manubrium, the breast, the aortic arch, of course, the heart here. And so oftentimes things can hide behind the heart and behind the sternum. So it's really helpful for us to kind of triangulate like where in three-dimensional space a certain opacity or certain junkiness in the lungs might be sitting. So again, this is why radiologists want two views. We can't always get two views because sometimes the patient is very, very sick. And for example, they can't move. And so we might be only able to get one view. And yeah, again, just kind of highlighting the importance of kind of the side view and the head-on view. So I hope you guys find this insightful. So case number 2. So this is a case of a 58-year-old male. Of course, we have what we call positive arrow sign, kind of a joke in radiology, like, okay, something's there. This patient has history of coronary artery disease or heart disease, so heart problems, also presenting with dyspnea or shortness of breath or difficulty breathing. And then he has something that we call orthopnea, and that is basically when you feel better when you have to sit up in bed with like a couple pillows at night. And this patient also has an elevated respiratory rate of 30 per minute, so 30 breaths per minute, or tachypnea as we called it earlier. On physical exam, they might have something called rales, which are certain types of lung sounds. And so let's see what you guys think the diagnosis might be here. You guys were pretty close to it earlier, so based on the answers that you guys suggested. So you guys are doing great. So of course, we might get some sort of basic labs for this person. Of course, we already got a history physical exam. You could do all sorts of different tests for these patients. You could, of course, get an electrocardiogram or an EKG to kind of look at the electrical conduction of the heart. Of course, you can get imaging as we have here. You can get biomarkers to look at the blood. Let's say you can get a set of troponins, which are a marker of cardiac damage or a heart attack or acute coronary syndrome. Perfect. So yeah, we have basically fluid in the lungs. So I like that someone suggested COPD because I don't have a chest x-ray of COPD, but you can just pull up a tab on your computer and kind of Google the chest x-ray radiology findings of COPD, because you kind of have this hyperinflation of the lung fields and kind of flattening of the diaphragm, which is interesting. And you can, of course, compare it to all of the imaging that I've presented here. So this person has what we call fluffy, kind of bilateral, which means both sides, and they are periohilar because they are near the hilum. And you might call it like a bat wing configuration or an angel wing configuration of these opacities where the arrows are. And all of this is consistent with pulmonary alveolar edema. secondary to congestive heart failure. So you guys nailed it. So basically fluid in the lungs. So if the patient's asking you what's going on here, you can just say you have fluid in your lungs. And most likely you'll have to diurese this patient or have them kind of pee off the fluid. So awesome. Good job, guys. So another thing that we do when we order chest x-rays or any sort of imaging is always get the prior set of imaging. So if this patient has never had imaging before, then you can't pull up the priors. But if someone has come in multiple times and gotten chest x-rays, let's say for a chest tube that they had put in for any reason, let's say pneumothorax or collapsed lung, then you might want to kind of serially kind of monitor that to see how the collapsed lung is progressing. So it's just a funny picture from the office saying, it's the same picture. Yeah, they are maybe kind of the same pictures. So yeah, you always want to look at prior. So for example, if a patient had tuberculosis, you want to see if they had tuberculosis on a prior x-ray that, maybe they came to the emergency department like 5 years ago, and you can pull up the chest x-ray from there that they got for a different reason, and to see if they actually maybe had a cavitary lesion then, for example. So that's some x-ray stuff. So here is of course, radiology has a lot of diversity in pathology, as I kind of talked about before. Here's an ultrasound of the abdomen. We can see all sorts of structures here: liver, pancreas, IVC, of course, inferior vena cava. Of course, here, really nice imaging of kind of the abdomen. You see all the organs here laid out really nicely: kidneys, psoas muscles, of course, the bladder. We'll just continue moving on. Hopefully you guys find this somewhat educational. As you can tell, of course, there's a lot of anatomy. So radiology is very heavy in anatomy and also in pathology. Like pathology is basically like the study of disease and pathophysiology. Of course, another abdominal CT here. You can see kind of the intestines, the stomach, liver, kidneys, of course, the vertebra. This would be an abdominal MRI of the abdomen. So if you compare this to the prior, the CT scan looks a little different. So MRIs are really good for us for soft tissue stuff. Of course, we have the spleen here, a lot of the same anatomy, the IVC, the aorta here. So we really have to know all of the vasculature and all of the anatomy, really. So here we have the prostate gland, bladder, of course, femurs, all of the muscles here. So pelvic MRI for you all. Here we have an abdominal X-ray, and these are often done for foreign objects in someone's body. And today happens to be Friday, so some of the radiology Instagram community has dedicated Foreign Body Friday to kind of foreign bodies. And this happened to be a cookie jar. So, we see all sorts of funny stuff in radiology as well. I don't know if you guys can kind of see this here. This is kind of a funny meme from weeks ago. Yeah, just drop it in the chat if you see it. Yeah. Basically, the reason I have this is because someone asked me, what's the funniest thing you've seen up someone's butt? And I'm actually finishing up my emergency department rotation. And so I just kind of threw this on my Instagram, and people seem to really kind of find it funny. Of course, we get x-rays of all sorts of bones. Here's the knee x-ray. You see, again, the anatomy labeled for you guys: femur, tibia, patella, lateral condyle, medial condyle, fibula sitting over here. And x-rays of the bones are really, really good for seeing fractures and dislocations. And of course, if someone had orthopedic surgery, if like some of that hardware is malaligned or kind of loose, you can also see other things like soft tissue swelling and emphysematous changes. So another case here for you guys. So this would be a 45-year-old male, positive arrow sign, as we can see. This patient has a history of head trauma. So maybe maybe they slipped on ice, or they fell and hit their head, or some sort of motor vehicle accident, and something happened, they hit their head. So this is what we would call a lenticular-shaped, kind of hyper-intense lesion in the left frontal region. And this is a head CT. And then over here on the bone window, we can kind of see a fracture, the left frontal bone. So all of this is consistent with an epidural hematoma. So I just kind of wanted to go through a case like that because epidural hematomas are something worth knowing about. So yeah, like I said before, this is kind of the bone window. You could do a little bit of Googling about the different types of windowing for imaging. It's basically there's certain types of ways you can kind of change the settings on the software to better take a look at certain organs. So for example, there might be a lung window or a bone window or a brain window. So this is specific for the bones. This is kind of a funny kind of x-ray, of course, because patients don't often know that a fracture is the same thing as a broken bone. And truly, they are the same thing. So no fracture means no broken bone. And if someone tells you your bone is broken, then it means that it was indeed fractured. So this is an example of a fracture, of course. Here is an MRI of the brain, of course. So all of the anatomy again for us: frontal lobe, parietal lobe, occipital lobe, corpus callosum, lateral ventricle, thalamus, midbrain pons, medulla, and of course the spinal cord down here. Yeah, so I think neuroimaging is beautiful. I mean, this is going to be the last case here. Basically, we have positive arrow sign again. This would be a 40-year-old female who is presenting with blurry vision for the past 2 weeks, and kind of this is a classic. Once we get to the diagnosis, this is a classic kind of presentation and patient demographic. 40-year-old female, kind of blurry vision, 2 weeks, difficulty walking. So these lesions are what we call perioventricular, kind of globular foci, and they are consistent with multiple sclerosis plaques. A lot of you guys may be familiar with MS, and kind of blurry vision, difficulty walking is a common presentation, and right around this age is a common presentation as well. And I think it's like a 2-to-1 ratio, female to male. So yeah, that's yet another case. So real quick, just wanted to show you guys a really, really kind of beautiful, high resolution, 100 micron, 7 Tesla brain MRI of a 58-year-old female who passed away of non-neurological causes of death. And so her brain was donated as a specimen, and they scanned her brain in a MRI scanner for, I believe, 100 hours, so like over 3 days. And they got this really, really beautiful and finely detailed look at the brain anatomy. And so this is going to be a really nice contribution to, I think, medical research. Basically, for MRIs, the higher the strength of the magnet, the more detail that imaging has. So if you guys are interested in all of this stuff so far, here are some resources. Feel free to take a screenshot, of course. I think what you guys are doing here on Web Shatters is fantastic. So this is obviously a great resource, as well as YouTube, Instagram, and TikTok. These are some really fantastic radiologists that you can kind of learn more about from on social media and TikTok, YouTube, of course. Rad's Resident has a fantastic kind of answer and question blog. So definitely check out his website. And then I think the Undifferentiated Medical Student, he did really awesome podcast. He has several radiologists on there that I think you guys should all take a listen to kind of decide. He interviews different specialists, and you can kind of hear the insights into their specialty. And he asks really, really great questions. There's of course the American Medical Student Educators in Radiology, AMSTER. They have an awesome PDF guide if you want to match into radiology, if you want to start early and read that. And then of course Ben White, he is a radiologist, I believe, who's finishing residency soon, and I think he's in Texas, but he has a fantastic blog. And some of these images that we looked at, they came from Felston's, and this is just a classic textbook. So, people think radiology is easy, but it's not all black and white. There is a lot of gray area, because truly there is a lot of gray area. So that kind of wraps up what I want to talk about. Feel free to follow me on Instagram. Let your friends know if you guys find this presentation insightful, helpful, informative. Make sure you like kind of the video after this YouTube live stream is done, because that kind of helps the algorithms. Definitely reach out to me with questions. I check my Instagram DMs fairly regularly, even if I'm not posting. So definitely feel free to reach out. My TikTok, one of my TikToks had I think it has over 130,000 views now. It was just like a silly day in the life video. And then, check out my Instagram. Of course, I have really a lot of information on my Instagram stories and stuff. So feel free to drop questions in the chat box here, and then I'll just kind of answer them as we go. So the first question I see here is, does the average radiologist typically look at all types of imaging of all parts of the body? So that's a great question, because it depends. If you are in academics or at a large university center in a more urban area, then you would probably read only what you are fellowship trained in. In contrast, you might see a little bit more variety if you are a community radiologist or someone in private practice. So that's kind of how those things differentiate each other. I think Dr. Salini actually did a video on academics versus private practice that you might find insightful, and that's on YouTube. So those are some differences. And kind of the more community practice of radiology would probably be 25% of your specialty that you are subspecialty trained in, that you're actually reading, and then the rest will be kind of bread and butter, all types of imaging from all parts of the body. So another question here is why I chose diagnostic radiology over interventional. Yeah, great question. So that's something that I think everyone needs to decide for themselves, and see if they want to be doing procedures as part of their workflow. And I'm not talking about a few procedures, I'm talking about procedures all the time. So IR does some really cool stuff, but for me, I personally am not a super hands-on person. It's not that I don't feel comfortable being hands-on. Obviously I have the osteopathic manipulation and that training from my medical school, so I do feel comfortable, working with my hands. It's just not something that I feel the need to have in my workflow. And then, of course, I found this with surgery as well. It's just like being on your feet is a little bit more taxing for me. Like if you're on your feet for 8, 10, 12 hours a day, I just, it just didn't necessarily resonate with what I wanted my kind of work life to look like. And you want to think about what is going to make for not only like a happy career and a successful career, but you want to think about career longevity. And can I do this when I'm 50, when I'm 60, 65? Do I want to work until I'm 70, 75? So I found that diagnostic kind of lended itself for me, you kind of I could basically do the job for longer, I think. So those are some of the reasons why I chose diagnostic over interventional. And that's not to say one is better than the other or the other is worse than the other. So I hope that answers that question. Another question is, how has COVID affected your work? So I'm currently in intern year, and in intern year, we do kind of clinical work, and it's not so much diagnostic work. So I'm not really doing radiology full time right now. And COVID, of course it can fill the hospitals up, fill the ICUs up with COVID patients when things are spiking. Where I'm at in Minnesota now, that was a problem in November and December most recently. Recently, right now, for example, the hospital has kind of intermittently been full, but not necessarily full because of COVID. So that's one way it's affected work, because it kind of takes longer for patients to get beds if they need to be admitted and get care. Another way it's affected work is just the added stressor of like going to work and not knowing if you're going to pick something up because of, changing in the locker room into scrubs or using the bathroom or kind of logging into a computer because, we use shared computers. And so you don't know if you're going to pick it up and then bring it home. Now that I've gotten the vaccine, I feel a lot more comfortable in um, in that aspect. Like I don't feel like as stressed out because oftentimes you'll see a patient in the emergency department, for example, and they haven't gotten a COVID test yet, and you won't know if they're COVID positive or negative. And for all patients that come into the hospital who are admitted, we do get a COVID test. So when someone's like on the floors, let's say on the internal medicine service or in the ICU, like we know like what their COVID status is. So like if you have to wear a N95 or not. So, but still, even if you are wearing the N95, the pressure is still a little heavier. But now with the vaccine, that pressure I think is lifted somewhat because there are some preliminary data coming out. It is early data; it's unpublished, but it is showing that transmission is probably decreased by vaccination. So that's I think some fantastic news. Next question is, how can you differentiate between a broken bone and a torn ligament? So that is probably a question that I would ask a musculoskeletal radiologist because I don't have like a true deep knowledge into musculoskeletal pathology quite yet. So of course, the bone is where the bone is, and like you might see like a cortical irregularity, meaning like if this is the edge of the bone, it could be like broken, or there could be like a step off, or some sort of lucency or like blackness in the bone because bones are typically white. My understanding is that tendons and ligaments tend to be black on imaging, so you wouldn't expect them to be kind of where the bone is. So you just have to know where the anatomy is, where the ligament or tendon might be sitting. So someone had like a torn Achilles, for example, it would look different from like a broken bone. Yeah, how long did it take you to become comfortable with reading images on your own? So I'm still not comfortable reading images on my own. This is, what I presented here, some really basic stuff because you learn some basics of imaging in medical school. And of course, I might know a little bit more radiology than someone who's not going into the field, just because I've been surrounded by it a little bit more. But like I can't necessarily read all of these. Like I don't have all of that anatomy memorized quite yet. Of course, in 4 years, when I'm doing it like day in and day out, like right now I'm doing mostly clinical work. So I'm like taking care of patients and learning how to be kind of a general doctor before you become a specialist. So it takes, it takes 4 years, I'd say, to get comfortable at least reading your own images and then having your own dictation style on your report and all the verbiage and words that you like to use. And everyone's a little bit different in that aspect. Of course, I think, once you're a fellow, you're kind of treated more as like an attending. And then once you're early on in attending hood, of course, there's different challenges to me because once you're dictating your report, of course, it feels weird because you've always been a resident this whole time. So I think there's always, some sense of feeling uncomfortable or just, kind of imposter syndrome. So that just comes with time. So another question here is, can someone be trained in both diagnostic and interventional? That's a great question. The answer is yes. So if you become a interventional radiologist, you are boarded in both diagnostic and in interventional radiology. So basically, if you become let's say, pediatric radiologist, then you can become boarded in both diagnostic radiology and pediatric radiology. So you kind of get 2 board certifications. So you end up having a diploma from high school, from college, from medical school, from your intern year. You also have a piece of paper from your diagnostic radiology training and from your fellowship training. So you end up having a lot of pieces of paper to kind of show for your work. So great question. And because you can be DR and IR at the same time, a lot of times proceduralists or interventionalists, they will do a mix of interventional and diagnostic work. And that split, like I was saying before, could be like 50-50, or it could be like 70-30. So some people decide to read imaging on like a Saturday and then, do IR work like 4 or 5 days of the week outside of that. And, if you have extra time or vacation time that you want to use, you could also pick up like a side hustle, for example, and do more diagnostic work if you want to have that kind of mix of workflow. So
Thank you so much for this wonderful presentation. We really, really appreciate it, and for taking the time to answer all of our questions. Everyone learned so much. So thank you so much once again. For everyone still watching, the Google form has been posted in the chat box, and you have 30 minutes from now to answer those questions. And everyone, make sure you follow Dr. Parisis, sorry, on Instagram and TikTok to learn more from him. And once again, thank you so much.
No problem. Thank you for having me. It's been a pleasure. You guys asked some great questions, so keep up the good work.
Thank you once again, and I hope you have a great rest